Sure. As we know, the standard of care for patients with resectable non-small cell lung cancer has changed dramatically in the last few years, migrating largely to preoperative chemoimmunotherapy. This, however, is not the right treatment for patients with EGFR mutant non-small cell lung cancer. The NeoADAURA study looked to move osimertinib into the preoperative setting, evaluating the standard of care chemotherapy with placebo versus chemotherapy with osimertinib versus osimertinib monotherapy administered preoperatively, followed by surgery. The primary study endpoint was major pathologic response. Patients were permitted to receive standard of care adjuvant therapy, including adjuvant osimertinib. I think the results support a personalized preoperative therapy approach for patients with EGFR mutant non-small cell lung cancer. Both osimertinib monotherapy and osimertinib with chemotherapy were better than chemotherapy alone, with no added safety signals. More patients went to surgery, and there was a much better pathologic response rate. The definition of surrogacy will be a little difficult to discern from this study. All patients were permitted to receive adjuvant osimertinib, therefore potentially mitigating any surrogacy signal of the early endpoint. I think, however, we have to look at the totality of the data. This isn't a novel agent we're looking to demonstrate works. We're instead trying to find a different treatment paradigm for this patient population. And this endpoint will likely reflect the clinical benefit. However, it won't meet true surrogacy because the patients received adjuvant therapy. I think I have to be a little old school in these answers, and the first, of course, are tobacco cessation and lung cancer screening. Those are the absolute most important interventions. Thereafter, we need to improve personalized medicine and biomarkers to get to a place where we are treating every one of our patients in a multimodal way with the best therapy for their disease. That's a very big question. I'll try to tackle part of it. And first and foremost, I think we need to be innovative in understanding why some of these targeted therapies aren't eradicating disease in the same way immunotherapy can, and find ways to target persister cells through translational research and drug development. In terms of the multidisciplinary team, all of our patients with early stage lung cancer deserve that multidisciplinary approach. And of course, again, back to the personalized medicine, to give them the drugs most likely to cure their disease, or at least minimize it to a degree that surgery can remove it. Well, through the ASCO President's announcements earlier today, there are big initiatives ongoing to integrate big data and AI, and I think that's the way we as a cancer care society can work together, sharing data and integrating that data in the most sophisticated ways to figure out some of those subtleties about response and resistance that will allow us to personalize therapy with the goal of cure of all patients with lung cancer.